This is a Siemens cable machine underwater. USC has all of these machines here. So basically, this is done by Rex Ingram. Rex Ingram just passed away this past year. The clinic is named after him. He's the father of restorative dentistry at USC. He had the most beautiful hand skills. And literally, gold required good hand skills because gold is a soft, malleable metal. And you can actually, if you had a slight error or something, you could actually bend it or swedge it against the tooth tighter so that there was no line. But because we got such a good fit with the gold, this is the standard that porcelain restorations have to come up to. So if we cannot get the porcelain restoration to have the same fit, then it's considered inadequate. Okay. So maxillofacial defects is the correction of defects in the upper head, not only in the mouth, but from the shoulders on up. And it could be caused by tumors, cancer, surgery, traumatic injury, birth defects. And the appliances are the appliances used to restore function. And I'm just going to kind of go over this subspecialty that I do because my skills from dentistry allow me to treat things more than just teeth. Okay. So this is an orbital defect. And this patient had a cancer that required enucleation. It looks kind of tough, but you know, she still has vision. And we use dental implant technology to have magnet retained prosthesis. Same with the nose. Okay? And when you think of things, I don't have the thing, you know, if you had have both of you said studies in cancer? Not really, kind of. Well, squamous cell carcinoma is probably the most aggressive type of cancer you can get. It metastasizes and spreads very easily. You don't want to get it, okay? There are other carcinomas that spread slower, but squamous cell is very aggressive, and once it starts, it can go into the nodes, and it could cause problems. So if we were to, like, say, make a pedicle and cover this, and she had a spread later on, you'd never see it, okay? So one of the advantages of this is the nose is just there to block air so she can get her speech. Same with the eye, because there's communication with the sinus. If you have a big nose, a hole here, it's hard for you to speak because the air comes out. It's like having a big nostril. Okay. Maxillofacial pros is a really, I think I really love it because the fact that it interacts with so much more of the patient than just the teeth. I have to teach patients how to chew, how to speak, how to think, you know? Think about it. And it's true, you do have to learn how to think, you know? You could think of what you're missing or think of what you have, right? Some of them, well, I don't have my nose, I need my nose back. No, you have it's kind of like you've got a nose that's now kind of like the hood to the engine of your car so you can go check to see if things are wrong. You have access. Ear appliances are easy to restore. And if you do bone conduct, this is really old, like 20 years old. And also maxillofacial prosthodontists work in the cancer centers with head and neck cancer patients and work very closely with oral surgeons. Oral surgeons like us because we're the ones, after they do huge surgeries, we're the ones that can actually get the denture to fit, the teeth to fit, or the prosthetic device to make the patient whole again. And what radiation does is, radiation attacks the periosteal layer of the bone, so the bone can no longer repair itself. Okay? Think about it. If your bone doesn't repair itself and you take out a tooth and there's a hole, what happens to that hole if you have too much radiation? It doesn't close up. Now you put that in your jaw, and the hole, instead of closing, gets bigger, bigger, bigger. Pretty soon you end up with a pathologic fracture, and you end up with a jaw that's in 2 pieces. It's miserable. So what we do is we have a protocol for patients treated with radiation, where we take out the teeth before they get the radiation so that the gums heal up first. Then, if they have tooth problems, like this was caused by the radiation, we should, like this sequester, we actually do not treat this. This will, it'll slow, it's kind of a little stinky, but at least the jaw doesn't become fractured. And they can keep this clean with oral rinses. This is kind of an area of dentistry you guys didn't know about, right? Also, from 2005 on, there's an area of where medications were found to affect how bone heals. And you folks might have parents or grandparents or something that have used bisphosphonates such as Fosamax. You know? Fosamax is a medication that's prescribed for osteopenia, where the calcium depletion occurs and then people get really brittle bones. But what they found was that it stopped the osteoclast. You had biology, right? Stopped the osteoclast from actually functioning. So the homeostasis pattern of the osteoclast, osteoblast, the bone actually stopped healing, and you had a situation similar to radiation, only it was just as bad, only it was systemic. Radiation is just to one area. Medication-induced bone problems are the whole body. Okay, this is a kid that had radiation, and a 14-year-old should have all the teeth erupted by now, but he's got, you see where the radiation is called delayed eruption. And this is a situation where we have a surgical resection, and from the radiation, the area never healed, and he ended up with a pathologic fracture. Radiation planning. Maxillofacial prosthodontists work with radiologists and planning what areas of the mouth or the head and neck can be actually treated. Yes?
So when the bone doesn't heal, that just happens randomly, right? That's not like overexposure to radiation, or is it?
The radiation, you would know how much radiation is in each field. Now, these are really old photos, because now this is all on a computer screen overlay, okay? And if you were to look at this, this is the dentition, and you can see a nasopharyngeal areas all in the field, but the teeth and jaws aren't. So if you had this as your treatment planning evidence, you would know that you could do treatment of the areas that are not in the field of treatment safely, okay? Based on knowing where the cancer is. Now on this patient where the base of the tongue cancer is, you pull the films out, and then you know that, oh, his whole lower jaw has been in the field. And then you know, oh, he had 6,600 centigrade doses of radiation. Then you know, I cannot take these teeth out, or I cannot put implants. So you make dental decisions based on the medical document that you pull and talking to the physician. A long time ago, okay, we had, people used to say, oh, you applied to dental school. You didn't get into medical school? It doesn't work that way. It really doesn't work that way. There's a lot of, I'm much happier doing what I'm doing now than if I did the 4 years of medical school thing. Are you sure? Because the medical school thing is not for everybody. It's very doable and it's very rewarding, and you got to really love the hospital environment. I was in the OR all morning. So, it's fun. It's a separate thing, and I encourage you to volunteer and learn about it. But my point is that as a well-trained dentist, you are on equal level with any of the medical physician specialties. And you can talk even one-to-one on them, and you don't have to think bad, because you're serving a specific need that they cannot serve. Okay? So this is just some other views of the same type of areas that are treated. And as dentists, you know, we use the same technology for sports mouth guards. And here we use it to deliver fluoride and protect radiation backscatter of the cheek. And these are just some appliances. We make all sorts of appliances. When patients don't have this type of treatment, the dentition breaks down really dramatically. So this is gradual panorex with the dentition when the patient doesn't maintain after radiation. And you can see it's just really broken down tremendously. So these are what post-surgical defects look like that I deal with. These are upper jaw. This is the upper jaw, no teeth. This is the view from the mouth, and this is the nasal sinus. This is a similar view. And here we have a couple of implants to hold a denture appliance in place. And these are just more examples, more implants, more defects. This is a normal ridge with no teeth. This is a partial remaining ridge, and this is the defect. And here's the defect, and there's teeth. And all these defects, they're, if you weren't trained or you weren't familiar, yeah, they can be kind of scary, but I'll just tell you that you can be comfortable working with these patients, because after all the surgery, these people are pretty much normal. Okay? The surgery, the cancer, the disease, that's what you're getting rid of. But the people inside, is the same person pre-surgically you talk to is going to be there after you talk to them as long as you take good care of them. And they're very, very appreciative of what your efforts. So these are some of the appliances that prosthodontists make. This is called an obturator because it blocks the liquid from coming out the nose. Orange juice through the nose is not cool. So we grab, using clasp, we grab onto as much of the remaining dentition as possible. This is the framework that is processed into this. So we make this framework first, and then we pry it in, and then we make the acrylic resin obturator portion secondarily, a separate visit. We probably make things in about 3 or 4 steps. And the reason I explain it to you, it's not really confusing, it's pretty easy to understand. And this is just an example of an upper and lower denture and an implant. 2 implants is all the difference in the world for a patient that ordinarily in the past couldn't eat hardly anything. This is a patient had 4 implants. And here's a patient where it had a lower jaw resection. And when they have the lower jaw missing, the tongue gets sutured in place, and you really don't have, you lose all your control, because instead of having 2 joints, you have 1, and it becomes a universal joint, and there's no coordination and control. So what we do is I designed the implant bar. This is a normal implant bar with 2 joints. I have to design the implant bar so that it rotates to where the 1 remaining joint is. The surgery was on this side. And this is the patient after surgery. You can see she had a neck dissection, lived through everything, small prosthetic appliance, but she can chew and swallow. She gets along okay, and looks most important thing, socially she looks good for the rest of the family. This is another, it's important, you know, because, you know, think about it. If it's your grandparents, they're afraid of them scaring you if you had of not being recognized. So this lady, this is a completely reconstructed lower jaw from a fibula free flap. That means this patient had radiation, and the radiation killed the blood vessels, So the surgeon and plastic surgeons take a chunk of bone with living tissue and the blood vessels. The blood vessels are rehooked up to the carotid artery so that the bone segment will live. And then the bone segment grows into where the jaw is because the soft tissues are so damaged by the radiation. We can make devices that have an amazing ability to look pretty darn good just using silicone. We use the pink wax that we use for dentures, we carve them up, and then using a lost wax mold technique, we actually process a silicone appliance that's glued in place or snapped in place. Now, this is an example of somebody that elected for plastic surgery. Okay. I'd rather have the sculpted nose than this thing, but this was okay for her. This is really okay. If she likes it, I like it. You know, you cannot get into the head of every patient, nor should you, but just understanding him and supporting him is your best, is what your job is to do. Sometimes you get really small appliances, and to understand how they're done, you know, we use the same techniques and technology I use to fix teeth. So here's the defect. Main thing is always protect the airway. So I put some gauze in there so it doesn't go into areas that I cannot pull the impression material out. Then I use the alginate that I use to make a mold of the teeth. And then there's no mold, it's soft. So what I do is I put gauze and stone over it to make firm up the mold. So I make it in three layers. I make a stone cap, then I can wax up the defect very slowly. I take a piece of wax, and first thing is I position the ocular, which is just the eyeball only. And the most important thing on that is having an artistic sense of knowing that the reflection of the pupil is the most important thing because that shows a gaze, and you want to have a neutral central gaze. Then, after that, we put on the medial and lateral canthus, which is where the eyelids open. And you have to, what you do is you use your artistic sense where we limit the amount of sclera that shows to match the contralateral side. Okay. Prosthodontists, I will tell you, love to go to art museums because it's the same skill. And it's not work, it's play.
Sorry, students have class at 6.
Okay.
Sorry.
We'll be done. And this is, we put a lot of some stippling on there and some shaping. Then we melt out the mold and inject the lightest colored silicone. And the silicone is then painted. So even though this looks really white here, right? Art from all the great masters in all the greatest Louvre, any of the Rembrandt, paint is put on in layers. And when it's put on in layers, it gives things depth. And depth adds realism. And once you understand that, we start with 3 colors, and mixing 3 colors, we can get the greens, we can get the browns, and then we put this on in layers. So here's the first layer, about the 3rd layer of paint, and we do it over maybe 2 or 3 days.
What? No
Looks
way.
pretty good, right? Yeah. It's not that hard once I've explained how it's done. Okay? Same thing. Okay? A defect is a defect. Okay? But once you learn the skill set and you have the training, you can complete any project. Okay? So, same principles, where to put the implants, where can we not put implants. Here she had a little bit of radiation, and so one of the implants failed, I think right around here. There, one implant failed, that's the red arrow. Same surgical sculpting sense, paint. And the implants retain it. She's fine with one eye. Pete Carroll. Always compete, concentrate on what you do well, not what you don't do. And you guys will be really successful, okay? So I can stick around for questions, or you guys can go to class, okay?
Like, how long does something like that take? You know?